All right, good morning. My name is Mary Leonard. I'm chair of the Department of Pediatrics, and it's my great pleasure to welcome you to this morning's Pediatric Grand Rounds. Such a wonderful way to kick off Black History Month. We'll be hearing about honoring the past and stepping into the future, centering health equity in pediatrics. As always, I want to call your attention to the code on the left, get CME credit. We'll put this in the chat for your convenience. And also, I suspect that many of you will want to share today's presentation with your colleagues who are unable to attend. The videos are available on YouTube and can be reached through the Department of Pediatrics website. Next slide, please. All right, just want to call your attention to a couple upcoming events of note. Next week is for Grand Rounds. As you may know, we have a quality improvement series. And this will be lessons learned in quality, safety, and service in 4 years at Stanford Children's Health. Lane Donnelly, who is our Chief Quality Officer, unfortunately is moving on to a new opportunity. And so we really encourage everyone to attend his final presentation next week. Next slide. All right, and I hope you all know that the Maternal and Child Health Research Institute does monthly educational seminars. They're really fantastic. This one is no exception. Dr. Key and Chavez will be presenting on high throughput neuroscience research and 22q11 deletion syndrome by a novel CRISPR toolbox. We have a very large 22q deletion syndrome program through the Research Institute. Next slide. And also we're continuing to try to find ways to better support clinical research through the Clinical Research Support Office. And this presentation here on epic research features available to you now to make your life easier. Please attend, encourage, and also encourage your research staff to attend. We're so fortunate that CJO is the research informatics manager embedded within the hospital and is now joined by a new employee, Trisha, who's helping him in this work as the program gets bigger and bigger. Next slide. And also another save the date in a perinatal conference, so on March 24th through 25th. Next slide. And last, very importantly, is we're coming up on the 13th annual Pediatrics Research Retreat. It is in person, so please make all the effort to attend. It's such a wonderful day, especially to interact with our trainees. We have student, resident, fellow, postdoc, instructors, staff, and faculty of all disciplines who share the latest research developments in their field. And this is a moment, I wanted to thank the Pediatric Grand Rounds Committee and the Pediatric Research Retreat Committee. The Grand Rounds Committee for the very thoughtful presentations, as example is today's speaker, chaired by Alan Schroeder, and then the Pediatrics Research Retreat. For both of these, Allison Guerin really has been an extraordinary force of nature for these lineups. So I want to give her a special thanks. So with that, I'm going to pass off to Baraka Floyd, who I'm sure you all know is our Associate Chair for Diversity, Equity, and Inclusion, who's going to be introducing today's speaker. Baraka, thank you.
So excited to introduce today's speaker. I'll briefly go over her bio so that we have enough time to ask questions at the end. Dr. Nia Heard-Garris is a pediatrician and physician investigator at the Ann and Robert H. Lurie Children's Hospital of Chicago and in the Department of Pediatrics at Northwestern University Feinberg School of Medicine. She examines the influence of social adversities experienced in childhood and subsequent child and adolescent health. And Dr. Heard-Garris is interested in the factors that contribute to a child's ability to thrive despite these experiences. Her work is federally funded by the National Heart, Lung, and Blood Institute and investigates adolescent cardiometabolic health, as well as approaches to empowerment and resilience. She believes in using research to better inform clinical practice and policy that supports children, their families, and their communities. Dr. Heard-Garris proudly serves as the inaugural Associate Editor for Health Equity Research for the Journal of Developmental and Behavioral Pediatrics, and she's also an active member in the American Academy of Pediatrics and serves as the chair and founding member of the section of Minority Health, Equity, and Inclusion. Dr. Heard-Garris completed a prestigious Robert Wood Johnson Clinical Scholars Fellowship at the University of Michigan and earned her Master's of Science in Health and Healthcare Research. She received her Doctor of Medicine from Howard University College of Medicine and her Bachelor's of Science in Biology at Spelman College in Atlanta. Dr. Heard-Garris, her husband and 9-year-old son live in Chicago, and as new Chicagoans, they better understand the phrase, winter is coming. So without further ado, our Black History Month speaker, Dr. Nia Heard-Garris.
Thank you so much for that warm introduction. I'm really, really happy to be here. I wish I could be there with you all physically because we literally are digging out of 10 inches of snow right now. So I am really hoping that the weather is better where you are. And I also want to wish you all a happy Black History Month. I hope that through this talk we can honor the past and step into the future by centering health equity in pediatrics. This title slide has an African-American family from the rural South arriving in Chicago in 1920. Though this is not my family, they made a similar journey from Alabama and Georgia to Cincinnati, and it's on their amazing, broad, fantastic shoulders that I stand. Okay, I have some disclosures that Dr. Floyd mentioned. I will have this up for a second, and then. So I speak to you from Chicago, and I'd like to acknowledge the peoples that settled in this land long before I got here. It's the Ojibwe people, the Ottawa, the Potawatomi nations, and many other tribes. Chicago is home to one of the largest urban American Indian communities in the U.S., over 22,000 people. So by the end of this talk, I expect that you'll understand the background information on ACEs, identify examples of how ACEs and racism intersect, impact children and adolescents, demonstrate the role of ACEs and racism as influencers of health in youth, and explain how to incorporate health equity and social justice in pediatric academics. So before I begin, I'd like to start this talk by paying homage to two phenomenal people who should be honored as trailblazers of history and present-day leader. So I know we just celebrated Women Physicians Day yesterday, and a nod to Dr. Blackwell's courage and pioneering for women to enter medicine. I'd also like to call attention to Dr. Rebecca Lee Crumpler, who was the first Black woman to become a doctor in the U.S. Dr. Crumpler worked as a nurse for 8 years until applying to med school in 1860 at the New England Female Medical College. She was accepted and would go on to graduate 4 years later. We know very little about her career, except for that she worked for the Freedmen's Bureau in Virginia and later practiced in Beacon Hill, which was Boston's predominantly Black neighborhood at the time, and published a book. I'd also like to introduce or reintroduce you to Dr. Angela Davis, who's an internationally recognized activist, scholar, organizer, and leader. Initially was removed from her professor position at UCLA due to her membership in the Communist Party, which later sparked a national discussion and conversation about academic freedom. This was followed by FBI persecution and incarceration. Dr. Davis's tenure has focused largely on social consciousness, industrial complex, feminism, LGBTQ plus rights, and I use Dr. Davis's quotes all throughout the talk, so I thought it would be important to honor her here. In a racist society, it's not enough to be non-racist. We must be anti-racist. We're going to start with some background on ACEs. So the original Adverse Childhood Experience, or ACEs study, was conducted from 1995 to 97 and included 17,000 patients receiving health maintenance exam in Southern California, and Dr. Folletti, who was the lead study author, found that certain adverse experiences were common in childhood. These adverse experiences were categorized into 3 groups: abuse, neglect, and household dysfunction. I don't like that word, so I'll usually say household problems or circumstances. Those are then categorized further into physical, emotional, and sexual abuse, physical and emotional neglect. Household problems include household members with mental illness or incarcerated relatives, domestic violence, or a household member with substance abuse, or if parents were divorced. These individual ACEs are added together to produce a score. We don't take into account how many times a particular event has happened, just if it's happened or not, and then they're summed. However, it was recognized that the initial ACEs led by Dr. Folletti may not have adequately encompassed the breadth of adversity that minority, low-income, and urban children experience, so Dr. Roy Wade of CHOP and his co-authors helped to capture additional experiences, known as the expanded ACEs. So these ACEs include discrimination, economic hardship, negative life events, parental psychopathology, bullying, and community violence exposure. So why do we care about ACEs? We care about ACEs because ACEs impact both the individual person, but also the larger community. When we examine ACEs on the individual level, generally we talk about influence on genes and the brain, health behaviors, and health outcomes. And while I won't go into that super in-depth, I just wanted to give you some information in that ACEs impact genetics and physiology. So ACEs influence epigenetic changes in DNA and activate and deactivate certain genes, and also impact brain architecture. So adversity can affect the synapses of the brain. So in childhood, millions of new neuronal synapses or connections are being more positive and nurturing environments lend themselves to the promotion of these connections that support learning and development. But when children are deprived of these environments, this can fundamentally change the architecture of their brain. I'm not going to quiz you on the different parts of the brain that are important for this, but I just wanted to remind you of specific regions, the prefrontal cortex, amygdala, and hippocampus. In the phase of adversity, the prefrontal cortex, which supports executive function and regulates emotion, can decrease in size. The amygdala, which is the fear center and decider of threatening versus non-threatening stimuli, actually increases in size. And children with severe adversity can have difficulty determining whether something is threatening or not. And then finally, the hippocampus, or the center of short-term memory, that helps to put fear in context, actually decreases in size. And so it also impacts health behavior. So individuals that are exposed to ACEs are 10 times more likely to use illicit injection drugs, 7 times more likely to struggle with alcoholism, twice as likely to have ischemic heart disease or stroke, and 1.5 times more likely to have diabetes or cancer in adults. This is why we care about ACEs. Now let's talk about racism. I want to start by defining it because when people say racism, they mean very different things. So today we're talking about structural racism. Structural racism is a system which confers differential access to societal goods or services and opportunities that are based on race or other physical properties. It's reflected in disparities that are related to but not limited to health, wealth, income, justice, and voting. It also unfairly advantages individuals belonging to certain social and political dominant racial groups. Racism can be structural, institutional, interpersonal, or internalized. We're not going to talk much about those other types today. So now you know what ACEs are, you know why they're important. I've defined structural racism for you, and these might be topics that you've already known about. But right now, I'm going to talk about something that I feel like is less frequently talked about, which is the intersection of these two, and how I think you can't fully have a conversation about ACEs without talking about race or racism. This is my very favorite graphic. I borrowed it from colleagues at the University of Chicago. I like it because it's here adversity is conceptualized as a tree. And if you can follow with me, I want you to start at the very bottom of this picture. So this is the soil. It is the adverse collective historical experiences that a group might experience together, like slavery, genocide, mass incarceration, displacement, and the Holocaust. The roots of this adversity tree are in that soil, and the roots are the adverse community environment. So that's racism, discrimination, community violence, lack of educational, economic, or housing opportunities. And then that gives rise then to the leaves and branches of this adversity tree, which are the adverse childhood experiences and the ACEs that we just went through. So an important intersection between ACEs and racism is incarceration, because those things actually work together to influence the health and well-being of children and young adults as they grow up. So while incarceration of a parent is considered an original ACE, I also want you to understand that there has specific disproportionate impact on children and families. So 5 million children in the U.S. have a parent that they've lived with go to jail or prison. It's the highest incarceration rate in the world, and this is only taking into account parents that the child has lived with, so not non-residential parents. That number is probably much higher. We know that Black and Hispanic children, rural children, and low-income children experience disproportionately high rates of parental incarceration. And while the majority experience the incarceration of their fathers, maternal incarceration is increasingly more common due to the rising incarceration rates of women. Having a parent incarcerated is detrimental to health. Specifically, those with a parental incarceration history have a higher prevalence of asthma, HIV or AIDS, and depression, anxiety, and PTSD. And through some of the work that I've done, I've also found that parental incarceration influences healthcare use. So young adults that have had a mother incarcerated have 2 times the odds of using the emergency room or a non-primary care setting as their usual source of care. They're also less likely to have dental care. And those with father incarceration histories actually have higher odds of using mental health services. Those with father incarceration histories are more likely to watch 50 hours or more of TV per week. This was before Netflix and the pandemic. And also more likely to drink 4 or more sugary drinks per week. And then also less likely to use sunscreen. Those with any parental incarceration history had over 1.5 times the odds of smoking cigarettes, higher odds of problem drinking, and IV drug use or prescription drug use. Any history of parental incarceration was associated with 10 or more lifetime sexual partners. Young adults with a history of mother incarceration had twice the odds of having sex in exchange for money. In parental incarceration, we did not find any association with higher odds of gambling. So in summary, we found that young adults that had a history of parental incarceration during their childhood were more likely to skip medical care, misuse or abuse prescription drugs, and engage in risky sexual practices. And given the way that incarceration is patterned in the U.S., higher rates of incarceration of Black and Latinx individuals, those impacts likely have a disproportionate impact on Black, Latinx children at. So just as we think of genetic mutations potentially impacting future generations, we too should think about incarceration impacting future generations as well. One of the other studies that I conducted, we found that specifically 1 in every 100 U.S. children that have experienced parental incarceration were also later involved in the juvenile justice. 1 in every 100 U.S. We also found that having both of these exposures, having a parent incarcerated and also being involved in the justice system later in life, was associated with adverse mental health conditions, including depression, anxiety, and PTSD, that box on the far right. So we've talked a little bit about ACEs and how ACEs influence health, and I now want to pivot to talking a lot more about racism. So when I first expressed my interest in studying racism, many people said, "You're a physician, you're not a sociologist, you're not an anthropologist, like, why are you studying racism? Why do you care so much?" Thankfully, I don't have to answer that question any longer, given racism being more in the American consciousness. But if I did, I would echo Dr. Kamara P. Jones's words that racism saps the strength of our entire society. And especially as physicians and pediatric providers, it is important to know that racism influences health. So we absolutely should care and think about it, talk about, and study racism. So this is a conceptual model that I'm going to walk you through. It's also one of my favorite graphics. It's really text heavy, so I'm going to try to walk you through it bit by bit to show you how racism gets under the skin and impacts health on a physiological but also a population level. So exposure to racism is associated with negative psychological and biological responses, which then translate into health outcomes and subsequently disparities at the population level. And I showed you before that discrimination was included as an expanded ACE, and researchers and physicians really should include and research the influence of racism on health. But right now, I want you to see granularly how this translates. So exposure can happen to racism at the microsystem and the macrosystem level. We'll come back to that. But then those exposures translate into physiological and psychological responses with some very familiar mechanisms as ACEs. So here you see depression, hopelessness, anxiety, as well as decreased immune function, increased cortisol, and blood pressure. And then those translate into increased risk of premature birth and infant mortality, risky behavior, illnesses, disease. Here, this study was done years ago, but if I could redo the conceptual model, I would put COVID-19 on this last bullet here too. So what are the micro and macro level exposures that I alluded to earlier? At the macro level, it's exposure to media, schools, policies, policing, and other authority figures. At the micro level, it's experiences with teasing, vicarious exposures, socialization. So how does one learn how to be a little Black boy growing up in the world? And that's told to those children directly, but also indirectly, and how they behave and what things they're exposed to, and parenting. So I co-authored a study with Dr. Ashanta Anderson where we use the National Survey of Child Health to understand the health of children as reported by their parents exposed to racial discrimination. We did propensity score matching analysis to compare discrimination exposed to non-exposed children. And we found that children with exposure to racial discrimination had lower reports of excellent health, and children who experienced discrimination were more likely to have depression and anxiety, which were linked to lower odds of excellent health. The negative health associations here may be mediated by mental health. Okay, so what does this look like in present day? We just talked a lot about incarceration, and I'm putting it here again just to drive home the point that incarceration is an important intersection between racism and ACEs, because again, it is an individual ACE. It's the initial ACE that Dr. Folletti examined, but it also intersects with racism given the policies, racial profiling, mandatory minimum sentencing, and all of those that disproportionately put away Black and brown young adults. Another important intersection for me, and I hope people are learning more about this. When I first started this work, no one knew what vicarious racism was, but it also looks like vicarious racism. ACEs and racism intersect here. So remember back to our adversity tree and think about the roots and remember those collective historical experiences as a way to understand this intersection. Vicarious racism is a really good example of this. So vicarious racism is racism experienced secondhand, and I'll tell you a personal story. So in residency is where I really began to think about vicarious racism and understand. I was pregnant with my son in residency, who inherently would be a Black male because I'm Black. I'm a Black woman. And it was around the same time that Trayvon Martin was killed, a Black teen in his dad's neighborhood because he looked suspicious. So though I didn't know Trayvon Martin or his family, I wasn't from Florida, I didn't have any connection there, I was devastated. And in essence, I was about to bring my son into a world that wasn't ready for him. I used to have a hard time getting folks to understand what this vicarious impact was or vicarious racism was. But given our last few years, I think people can more easily understand this concept now since it's become kind of front and center in the news media and on our. So back again, when I first started this work, vicarious racism, there wasn't a lot of information out. I did a systematic lit review. We looked at 1,400 articles to understand the state of the literature and found that at that time, at least 50% showed that vicarious racism was associated with decreased healthcare use, worse socio-emotional health, and mental health. The systematic review mostly included articles, though, that discuss racism through the eyes, vicarious racism through the eyes of their parents. So essentially, a parent had some sort of racial discrimination, and then they reported on the health of the children. However, our team wanted to more fully understand how teens experience vicarious racism in the news and in social media. So one of our team studies, led by Dr. Alyssa Cohen, who's there and who is one of my current fellows who's looking for a job, so nudge, nudge, was really eye-opening for us. We worked together to recruit 18 teens to participate in focus groups. And the focus groups were recorded and transcribed and coded using qualitative methods. We asked teens to talk openly about racism that they saw in the news and social media, and we drew out a number of themes. I'm only going to briefly discuss 3 today. One of the themes was negative mood. Several teams were able to expand on vicarious racism and the impact of it in the news. the telling and retelling of news stories involving racism were noted by some to perpetuate their trauma. One participant said that they created a term specifically to describe the feelings of sadness and resignation related to the experience of vicarious racism. That teen said, some of my white counterparts who'd be like, hey, oh, this thing happened. How do you feel about it? And I'm like, I created the term melancholy as a response. So this participant used this term to describe their feelings around vicarious racism in the news and how the feelings of sadness continued to come up every time they saw this. Another theme that we discovered was around helplessness. I'm going to read just a few of these quotes because I recognize it's probably pretty hard to see on the side. So after a participant witnessed racially charged news said, sometimes I don't say anything. I'm just like, okay, another day in the life. I think it's become more of a norm seeing this stuff on the news and stuff. So when I see it, it's like, oh, this is happening again. I feel like this was a spot for me to be like, oh, wow, this is the country we live in. So yeah, I feel like I've gone numb to when someone will be like, oh, racism. I'll just be like, okay, yeah, sure. So here are some of the other themes that we identified. We found that many participants readily identified concerns around fake news on social media and describing saturation of racism in the news and feeling helpless. Many participants perceived this helplessness and negative mood changes after this exposure to racism on the news, but few associated it with changes in their own health, whether that was mental health or physical health or health behaviors. But you did indicate that peer discussion was an important mechanism for coping to vicarious racism in the news. I also really appreciated the study, like drawing out what teens were feeling, how they were exposed to vicarious racism. However, it really got me thinking about the adversity tree again. And often when we intend to address ACEs or address racism, our work tends to be at that most visible or superficial levels of the tree, up at the top. So including even the interventions that I'm working on that I don't have time to talk about, we still need to contend with the roots and the soil, those community and historical levels. And I get that it's harder to do, but we continue to kind of work at the top, at the superficial levels, but need to think about the soil and the roots of this tree. So what I'm coming to discover is that activism actually might help us to get to the soil, the roots, a bit better. Activism may represent an important and constructive means by which adolescents themselves can cope and combat structural racism, maybe mitigate negative emotions and potentially prevent adverse health effects. There's still significant amount of work that needs to be done in this pediatric space and thinking about activism and health. But I think we can start to think about that for future work, and then also think about how we use activism within our own professions and within our own everyday life. I'm no longer accepting the things I cannot change. I am changing the things that I can. So how do we start to think about the roots in the soil, beginning with pediatrics, beginning with our own professions and how we interact with trainees within our institution? So I'm going to explain how I'm thinking about health equity and social justice in pediatric academic medicine. I know that there's a HEAL program at Stanford, and I am excited to learn more about all the things you all are working on too. As I think about medicine, academic medicine, I think about at least 4 facets that may help us as we work towards our anti-racism in our profession. The next few slides I will talk about will give you kind of small snippets from a recent paper I worked with Dr. Monique Gendel on recommendations for academic pediatrics to work towards anti-racism. These aren't all the recommendations, just a few to get you thinking about potential steps to move forward. So if you want more recommendations, I would recommend that you read the paper. So teaching. We teach trainees, but we also need to make sure that we create psychologically safe environments so that they can actually really be their authentic selves, grow, and learn. We need to train the next generation and expose them to the field early, maybe even before medical school, thinking about pipeline programs with our institutions, within our research spaces and our learning spaces. We need to center our field on principles of diversity, equity, and inclusion. Some of the ways I've started to think about this, and we talked about in the paper, are to implement actionable systems for reporting, investigating, and rectifying accounts of racism and microaggression. And then a way that trainees often will get to their next step is by recommendation letters. So analyzing and revising our recommendation letters to look for coded language in the letters to make sure that we are presenting their best selves so that they can get to their next step. On a research front, we engage in research, but we need to really think about research holistically and also diversify our research team. So I am encouraging everyone who does research and scholarly work, whether that's basic science, whether that's population health, and everything in between, to say and study racism, say the word racism. When I started to write in this way, I had to be very careful about how I worded things because reviewers, because editors, nobody was really ready to say the R word. And now there's an explosion of commentaries, of original science that really tries to delve into this. But, it can't just be a few scholars that are working in this spaces. We need to think about how we expand this to all of the work that we're doing. So when I think about racism, especially structural racism, I think of it as the thing that really drives some of the social and physical environmental exposures that I've talked about. So including ACEs, but also the social influencers or determinants of health, and then subsequently those health outcomes. So thinking about how do we bring some of the things that I talked about earlier in structural racism to the work that we're doing every day, an attempt to really understand and address those root causes. We need to build research teams that include, engage, and empower those that are underrepresented in medicine. So some of the ways I've started to think about this is trying to recruit those from minority-serving institutions, partnering with Hispanic-serving institutions, historically Black colleges and universities, and other places. So one of the ways, especially if there's not a Black college by, which I don't think there is, where you all are, is thinking about how do we open up, especially in this virtual environment, opportunities for internships and research work that can be done virtually for students that might not have opportunities to do that work. So not just limited to California, but limited that can go all throughout the nation potentially. And then this one is obviously very near and dear to my heart, but to hire, fund, publish, and cite Black scholars. So when you're looking at your research work and your works cited or your reference list, whose work do you typically highlight? Whose do you draw from? And making sure that that work represents the gamut of scholars in the field. From an administration standpoint, we run divisions, departments, clinics, and hospitals, but we may need to restructure them for success and understanding what success looks like. We need to align racial and equity work with promotion criteria. So again, I'd love to hear what's happening with the HEAL program and how that factors into promotion, but also ensuring DEI or EDI leadership positions are equipped with authority, status, budget, and influence to enact meaningful change. So it's great. I've seen a lot of institutions hire, chief diversity officers or associate diversity officers, but how much budget do they get? How many resources? How many staff people? What things can they actually do in the institution? That's important. So a title is great, but a title without power is actually more harmful. And then maybe most importantly of all, we care for patients. So within our clinical practices, we must put equity on the agenda and make it a top strategic priority. We need to consistently collect and accurately document patient race and ethnicity and language information and examine disparities. So a lot of us do QI or quality improvement work. If we're not accurately collecting that data, we will miss disparities, we will miss loopholes, and we will miss harm done to our patients if we're not actually collecting it accurately. And it doesn't mean that somebody at our front desk or register is checking what they think the patient is, but allowing people to self-identify if they choose to. And I recognize that many of us want to work within the field of pediatrics to make these changes because there's so much that needs to be done. And I know that others are going to want to go beyond the walls of our clinic and our hospital. And I think for us to become a more equitable and just society, we need both. We need those that are working within our field that are impacting trainees and research and clinic and QI, and we also need those outside of our walls that are dismantling racist policies at the federal, state, and local levels. So both are important. So because it's Black History Month, I thought I would do just kind of a brief reflection on kind of why I've come to this work. So because where I've come from, I feel compelled to do the work of adversity and struggle. I want to honor like all of the kings and queens and everyday heroes that have come before me and never in their wildest dreams thought of being able to do what I have the privilege of doing. For example, like how have my people gone through the transatlantic slave trade, gone through slavery, Jim Crow, the civil rights movement, war on drugs, the Great Recession and housing crisis, mass incarceration, the murders of Breonna Taylor, Ahmaud Arbery, George Floyd, Timothy Thomas, and too many more to name. Despite all that struggle, adversity, trauma, and collective ACEs, despite it all, have this amazing art, culture, music, ancient civilizations that existed before. Despite American history diminishing our existence to starting with slavery, started way beyond we came to these shores. We have power in Nat Turner's Rebellion, Harriet Tubman's bravery and courage. We had joy even during Reconstruction. Had voting and civic engagement. We had political success. Black senators, representatives, and local officials during Reconstruction, I think more than exists now. Of course, Reverend Dr. Martin Luther King. Representative Shirley Chisholm. The Black Power movement, liberation schools. Angela Davis. Million Man March. Obama's. Lisa Ray, who's a Stanford alum. Black Lives Matter movement. Who's now 9. So because of the work that I do, because of where I've come from, because of what my people have suffered and endured, but yet have risen from, I feel compelled to do this work. I also feel compelled to do the work of advocacy, and using scholarship and using voice to influence change. Honestly, I would argue just because of who we are as pediatricians, as pediatric providers, as those who care about the health and well-being of children, that this should be the work we all do. I feel like we should all be compelled to think about the ways in which structures seek to hold children back, hold their communities and families back, to prevent them from being their healthiest selves and thriving, learning, working. As a researcher who studies ACEs and racism, I think it's also important to study resilience, study thriving, to study positive experiences. As pediatric providers and pediatricians, we know what it takes to boost resilience. None of this stuff is a secret. We know that parks and safe neighborhoods and adults that believe in children and mentorship is important. We know that we need to shape schools and communities and societies so that children don't need to be resilient. They need anti-racist, anti-sexist, anti-transphobic, anti-homophobic, anti-ableist spaces. They need welcoming environments. They need inclusive spaces. All of this is important. We know this. Adversities in childhood are rooted in historical and modern day experiences that contribute to poor health in adulthood, and multi-sector strategies, including education, public health, research, medicine, and policy, are required to disrupt this negative trajectory. This will take committed pediatricians, scholar activists, and community and policy leaders. Sometimes we don't have to do the work. Sometimes we have to do the work, even though we don't yet see a glimmer on the horizon that it is actually going to be possible. So I'd like to thank the leadership at my hospital at Ann and Robert H. Lurie Children's Hospital of Chicago, the many co-authors and colleagues that I couldn't even really fit on this slide for pushing me and helping us to really make this work rigorous. My lab, which is the Arise Health Lab, I'll show a picture in it. I couldn't do the work that I do without these fine folks, and we have more and have subtracted some, but this is our most recent picture. And I'd like to thank all of you for embarking on this journey with me. You have to act as if it were possible to radically transform the world. You have to do it all of the time. So with that, I will stop screen sharing and see if there are any questions. Save enough time for them.
Thank you so much, Dr. Heard-Garris, for that inspiring presentation. I especially appreciated the historical context that you shared to go along with your work around adversity and resilience. One question I have is, you mentioned the concept of racial socialization, the way children learn what it means to be a Black child or Latinx child in society. As we're thinking about this, how can pediatricians impact racial socialization to build resilience?
That's a fantastic question. Thank you for that. So I don't claim to be a racial socialization expert. I know there are many in the field. Dr. Shanta Anderson, Dr. Rihanna Elise Anderson do a lot of this work. So I would encourage people to look them up if they haven't. But there are many different domains of racial socialization. Some of them are things that we wouldn't recommend. So some of them promote mistrust of a different race, but others promote like cultural pride and cultural awareness. So one of the things that, pediatricians could do, and I think there is a movement to make sure that this is happening, but if you all have Reach Out and Read in your clinical spaces, making sure that there are diverse books so that people, families can have books of those that look like them and maybe perhaps that don't, so that they can have a conversation about race and have a conversation about what does it mean to be Mexican American, what does it mean to be Indigenous or Native, and have that conversation. So that's small, right? Like having a book that reflects the patient population you serve. But it could also be like when there is, Black History Month or Hispanic Heritage Month, that you make sure that you intentionally have signage that says, we respect, we honor the great people that have helped to build this clinic, and name who those people are, especially if they're people from underrepresented group. I think that's really important. But encouraging parents to share their culture and share their heritage with their children. I know, at least clinically, when I practiced in DC, I had a lot of parents that were Latinx, or actually they were parents, but their parents didn't teach them Spanish and tried to make sure that they could speak English very fluently and didn't really have that culture, that tie to their heritage. And one of the things they would say to me is, I really want that for my kid. And I would try to encourage that because that is so important. That connection to your past, that connection to your ancestors and who you've come from, give you a better identity of who you are going in the future. And then not only that, there is research that has shown that children that do have a good sense of cultural identity and cultural awareness are less likely impacted by racism. They're still impacted, but if they know who they are and they know that there's a problem with the system versus there's a problem with them internally, they're better able to navigate that. So, not internalizing those feelings of helplessness and despair, but rather saying, oh, there's something wrong with society. It's not something inherent.
Thank you so much. One other question is, can you say something about how we can interact with other systems to affect children to improve their outcomes?
Yeah, I think this is another really good question. And I think it's been difficult to coordinate, like with the child welfare system, with the carceral system, even with the educational system as pediatricians. Like there's so many hoops that one generally has to jump through to even talk to a teacher or a psychologist or a social worker outside of our health system. And so one thing could be to try to have stakeholders to get all together and see if you can have a general universal consent so that you can talk to people that are across, sectors, whether they're in educational spaces, mental health spaces. I know that there are some communities that have been really working to have a universal consent so that we could have a free flow of exchange of information. But within the clinical spaces, with what is possible, if that doesn't yet exist, asking parents, I really am concerned that something's happening at school. Especially we've had in the last few weeks, people have brought to, at least in our clinical spaces, concerns about racism, concerns about microaggressions, concerns about, teachers not necessarily treating their child the same way as they would treat another child. And so being able to have those conversations with your but then having those conversations with the teachers. One school that I saw specifically, there was a student who said some racial slurs to another student, and instead of being very punitive to that student, they instead embodied these principles of restorative justice and having the child really do a whole research project and understand why it's harmful, what they did, and how they can make sure to never, inflict that same harm again. And so really thinking creatively with the schools about how to inform our next generation of kids.
How would you compare the influence of pediatricians in this work to the influence of school teachers, and how do you envision they could work together to address these issues? Kind of expanding on your last response.
Yeah, I think that pediatricians, honestly, were a little late to the game. I think other sectors have been working in these spaces a little bit longer than we have. I think there's a lot of interest now, so that's great. But there's been work on anti-bias classrooms and anti-racist classrooms, and what does it mean to have an anti-racist classroom? So what are kids learning? What kids are allowed to do? How they're able to come to school? What's allowable? There's a lot of research and books and all of that for teachers and support for teachers. I think that work is happening now within pediatrics, but we still have, in my opinion, a long way to go in those spaces. So I think, honestly, there's a lot that we could learn from teachers in this space and asking them, how are you thinking about anti-racism, anti-bias in the classroom, and trying to understand what we could adapt for our clinical spaces, our hospitals and our clinics, and policies even.
So I hear a thread of really purposeful collaboration, trying to make sure you maintain that connection. One of your recommendations was really to implement systems so that microaggressions can be not just reported, but also addressed in a way that's grounded in restorative justice. For institutions that are trying to set things up like this, how might they go about that?
Yeah, these are all really good questions. I think it is important that the systems are anonymous and the person that is making the report has the opportunity to identify themselves if they would like. If they are forced to be identified, sometimes it can discourage people from reporting, especially if there's a power differential. So if it's a resident and an attending, or a fellow and a resident, or, these different power dynamics are really important. So I would first recommend that it was an anonymous reporting system. the option of having people to identify. I know there's a little bit of controversy in that, because if it isn't truly actually anonymous, then how can you follow up if the allegation, is made and it's a serious one that needs more investigation? But I still think that making sure that it's an anonymous is an important way to at least gather some data in this space. And then the other way, especially from an acting standpoint, I think that's the hard part, is like when you get all of these reports, or when you get reports, what do you do about it? And how do people know that you're fully addressing it, especially if it's anonymous? How do you communicate back, like, we're working on this, we think that this is important, we're investigating it, or we have identified that this is a problem? So I know that many institutions have implemented or starting to think about implementing a racial equity dashboard that not only includes patient outcomes, like, are indigenous and native populations getting the flu vaccine as much as other populations are, but really, like, are we able to, these are X amount of number of incidents we've had in the last month. These were the steps that we took to, remedy those things. These are how many trainees that we reached out to recruit in this interview season. X amount were underrepresented minority, X were this and that, and these are how many that ultimately matched or came. So thinking about racial equity on a larger scale, not only patient outcomes, but thinking about it holistically with respect to the entire institution and the no.
You. Can you address how to best overcome mistrust, distrust that still exists within communities of color and medical profession with regard to treatment-seeking behavior?
Yeah, this is a tough one, because the mistrust or distrust, or however you want to, confidence even in medical advice, in treatments, and so on, is rooted in real historical and also present day trauma and issues, right? And so it's earned, and I think we as providers of all races and backgrounds, creeds, religions, all of that, need to earn that trust back. And right now, it happens patient by patient. Like, it is really hard to just take an eraser and erase all of that collective historical trauma that I talked about before. You can't just erase slavery. You can't just erase the Holocaust. You just cannot do that. And so instead, how can you make your sphere of influence, where you're practicing, wherever that is, a safe space, a space where people can actually be themselves and be authentically themselves and feel like they can have conversations with you. And so sometimes that's opening up the door and saying, I'm learning a lot about anti-racism and racism, and I know that sometimes that could be perpetuated even within healthcare and medicine. And I'm working really hard to make sure that that doesn't happen here. Have you had any experiences? I know we don't have a lot of time to do all the things that we need to do. But when you are able, it opens up the door to say, oh, this is a person that might actually get it, right? This is a person that can see me, because it's not okay to not see race. Everyone sees skin color. Everybody sees differences. We see it from the time we're like 2 years old. We can say, this person is different from me, right? So instead of turning a blind eye to those differences, embracing them and say, I get that I may not fully understand all of this, but I am trying to, and I want to be your advocate no matter what. And so it's not until you've earned that trust, then you can start to talk about mistrust and confidence and treatments. Until somebody trusts you, you can't make meaningful changes.
One of the other things you mentioned that you're interested in is resilience. Aside from ACEs and their measures that can assess, are there measures that can assess positive factors in a child's life?
A great question. There are. So people, and especially in the psychological spaces, I'm not a psychologist, have measured positive experiences, resilience, and thriving for a really long time, like before I got here. And so I don't want to belittle the work that's been done there, because I don't know every single measure. But in the spaces where I work, like resilience and thriving and positive experiences, there are a lot of scales, a lot of different scales, and so you kind of have to pick what has been validated in the population that you are working with. So there is a youth CRM scale. I'm trying to remember exactly what that stands for. I think it's by Dr. Unger. There is a PACES. I know a lot of people have come to ACEs work through PACES, which is positive experiences and ACEs. The HOPE, there is a HOPE collective of folks that are doing positive outcomes, and it's just HOPE, HOPE. It's Dr. Bob Sige out in Boston. I'm trying to think of other things that I've used in the past. Oh, and then there's a ton, like I said, of psychological measures of resilience versus flourishing and thriving. I know that the National Survey of Child Health uses some, I think they call them flourishing measures. I can't remember if they're flourishing or thriving measures, but flourishing measures. So there's some that are already in large data sets if you're trying to do like a secondary data analysis. But if you're trying to do primary data, you can certainly start in the psychological and sociological spaces and kind of look at the measures that I just mentioned too. There's a large playground out there of stuff.
Thank you so much. So much gratitude today for this amazing presentation and this really great scan of how racism, identity, adversity, and resilience can all work together. Just lots of gratitude in the Q&A. And I think at this point, we'll close for today. Oh, hold on. Just kidding. One more question. I think we have time.
Yeah.
Any thoughts about the potential outcome of the Supreme Court hearing case and the challenging affirmative action against Harvard and UNC? I think if I could frame that question, I would say one of the things I can hear in your recommendations is really the attention to assuring that diversity, equity, and inclusion are included in all of the things that we do. I'm really thinking about pathway programs and pipeline programs as an intervention. And I also hear a lot of undercurrent of how society is just not there yet in so many ways. Are there any thoughts that you would have about how pediatricians might be able to act in these situations?
Yeah, so and I'm going to talk to the residents, I think, about this on Tuesday, and maybe the fellows too, it sounds like, is using our voice and advocacy. So this talk, I tried to incorporate, a lot of research from myself, but other people too, because as a physician scientist, I think it's important to put data and science and evidence behind the stuff that I'm saying. But also on the other side of it, is thinking about how we use our advocacy. How do we use some of the science to then inform what we know is good for the health and well-being of children? So I am a former RWJ clinical scholar, and I say that with pride because I think what was important for me about that experience is that, I was able to work in policy spaces. And what I found limiting about it sometimes is that they really relied on, some of the people there relied on children just choosing the right thing for them, or just knowing, them just knowing what was best, and not always incorporating evidence and science. But as docs, as nurses, as scientists, we have access to evidence. We have evidence to best practices. Not always do they exist, but how can we use that evidence to help to inform policy and policy-making decisions, including how we make connections, how we bring underrepresented and frankly marginalized and disenfranchised people into the center. So people that we've systematically kept out of our institutions, out of our professions, out of our schools. How do we make sure that it is equitable? Because not everybody started life at the same place, right? Some people came into life with incredible wealth that was earned on the backs of slaves. Other people came in with nothing. And so how do we make sure that everyone has opportunities that they need to really thrive and health, well-being, joy in their life because they are afforded the opportunities that they need. So I don't know that I answered the specific question, but in general, I think we, especially those that are in the ivory towers, in which we are, owe it to the communities around us and to the larger community, the societal community, to ensure that we have the best talent, the best minds working on everything. And we know that talent is equally distributed in the population. But if we only have a certain group, right, that is constantly represented in those institutions, we don't get that diverse talent. We don't get the brightest minds from all sectors of society working on our most difficult problems in life. And that really does us a disservice. So that's my answer, not answer to the question.
Thank you so much for this wonderful presentation, Dr. Heard-Garris. We look forward to being able to spend a little bit more time with you this month.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.